Good morning, everyone. Thank you for joining us today for our chronic lung disease session that we're hosting. I want to first start off so we can all introduce ourselves real quick since we're a small group. I'm Kelly Guthrie, and I'm the West Virginia CTSI Program Coordinator for Project ECHO. Next, we will have Grace. Do you mind to go ahead and start off?
No, not at all. My name is Grace Ann Dorney-Koppel. I'm president of the Dorney-Koppel Foundation and support the Grace Ann Dorney Pulmonary Rehab Clinics in West Virginia and in other states as well. It's a joy to be with all of you.
Thank you so much. Diana?
Yes, good morning. I'm Diana Carpenter. I'm the program manager for the Rural Health Redesign Center in Harrisburg, Pennsylvania. Good morning, everyone.
Good to have you with us.
Yeah.
Erin?
Hi, I'm Erin Cardiopulmonary Director at Armstrong County Memorial Hospital in Kittanning, Pennsylvania.
All right. Jordan?
Hi, I'm Jordan. I work in Department of Medicine here at WVU, and I've been helping Dr. Abdullah with the chest ILD initiative.
All right, thank you. Do you know who else is logged in under your name?
I see I'm on here twice, but it's just me.
I think it might be Dr. Ahmad.
Oh, okay.
Might be I think I saw his face earlier.
All right. If the other person that's logged in under Jordan would like to introduce yourself. So Tara Miller doesn't have a microphone, but she is at WVU Medicine, Jackson General Hospital in Ripley, West Virginia, and she's a respiratory therapist there. Next, I have somebody logged in under a Kingwood number. Sorry, dear, we can't hear you.
Can you hear me now?
Yes, I can.
Okay. I'm Terry Hauser at Preston Memorial Hospital, and we're Grace Ann Dorney Pulmonary Rehab Center in Kingwood, West Virginia, and I'm an RN, and I'm the manager over the department.
All right, thank you. And Terry, do you have somebody else that's logged under your link as well?
No, I actually have the computer on so I can see the slides, but then I called in under the 329 number.
Okay, all right. Well, thank you everybody for joining us today. I'm gonna say this twice today. Our sessions are moving from 8 a.m. on Mondays to noon. I hope that we'll be able to accommodate everyone's schedules. I know a lot of people were having a hard time with it being so early when everyone just getting in and it's kind of a rush, especially on a Monday. So we will start meeting at noon on Mondays. So at this time, Dr. Abdullah.
Thank you, Kelly. Appreciate it. Good morning, everybody. It's an honor to be here. I know it's really early, so just bear with me, but I just want to make this an interactive talk. It's tough doing it online, but if you have any questions, please just put the hand up signal and chime in. Okay. So my name is Amirah Abdullah. I'm one of the pulmonologists currently working in West Virginia University in Morgantown, Ruby Memorial. And me and my team actually got a grant from CHEST to focus on interstitial lung disease, and especially for interstitial lung disease in West Virginia. And that's what the basis of this talk is about, okay? So the title is Time Loss is Lung Loss is Life's Loss. And the CHEST initiative in particular is called Bridging Specialties, Timely Diagnosis for ILD. So we do have funding from CHEST. We have funding from CHEST Physicians, which is a big organization that comes up with a lot of our pulmonary guidelines, ICU guidelines, from Three Lakes Foundations that had contributed to this grant, and West Virginia Department of Medicine itself. right? The purpose of this talk is not necessarily to teach you all I know about ILD, but to just introduce what are the things about ILD that can be picked up at a primary care level so that these patients can be managed in a more timely fashion. All right. So I am going to be talking about one patient story. I'm going to be talking about the common ILDs, the prognosis and treatment options. I also want to introduce the ILD toolkit, which is a toolkit that was created by CHEST for primary cares and for the initial physician that will be seeing these patients. And usually that's not me. I get patients sent to me, but I'm not the first one to catch these patients. And I also want to introduce our quality improvement project. So I had permission from Charles and his family for all these pictures. They were the ones who gave me all these pictures, and they gave me consent to use all these pictures to illustrate his story. Okay, so this is Charles on the left side. So Charles is a 59-year-old patient who initially saw me back in October 2021. And considering he's 59 years old, he had been on oxygen of 5 liters for the last 2 years, even before seeing me. He primarily got referred to me from his pulmonologist's office because of recurrent admissions to the hospital, and that's actually why he came to me. So I have a couple images of his CAT scan, which I'm going to play. So I know this is going pretty fast, but just to kind of highlight a couple of the findings I see on this one. So he has extensive emphysema, paraseptal, on the upper parts of the lungs. And as you go further down, you see more reticular changes, what we call as signs of fibrosis. Okay, so this gentleman, by the time he had come to me, had pretty extensive emphysema, but he also had pretty extensive fibrosis. So I want to talk about how his course played off. Okay, so he came to me in October 2021. At that point in time, he had he was already on 5 liters at that point in time of nasal cannula. And with walking, he would desaturate more, but he was able to maintain it on 5 liters. This is a patient who is very highly motivated to keep working. He was still mowing his lawn. He was still trying to stay active. The relevant past medical history that he has a history of a VATS back in 1990s for a pneumothorax, just an isolated lung. And he had a BMI of about 37 by the time he saw me. So when he first saw me back in October 2021, and, I saw his clinical course, I knew from the get-go that there really isn't too much I can do for this gentleman. Because, there's only so many limitations when it comes to interstitial lung disease management. When somebody is already on 5 liter nasal cannula, I can put him on antifibrotics. I can help treat his COPD, but it doesn't change the clinical course. So this is a patient that I referred for lung transplant almost immediately. And when I had sent him to lung transplant evaluation, he had gone into UPMC to be evaluated, but his BMI was 37 and the target they wanted it to be was 33. So this gentleman worked for the next 1 year to lose 60 pounds. Very, very highly motivated patient. He lost the 60 pounds, and subsequently he got 3 back-to-back admissions where, due to pneumothorax and COVID. And by the time he saw me back in 2022, he was now on 6 liters and 10 liters with exertion. This gentleman, in a matter of just one year. By this time, again, I sent him back to get evaluated for transplant, but UPMC wouldn't take his insurance, so he later had to be going to Ohio State, and he eventually got his transplant in 2022. So the reason I'm highlighting all of this is just to kind of highlight how long things play out even at my level, even after I see them. What is it that I can do for them? Okay. So the whole purpose of this talk is actually to highlight the delays of care in patients with ILD. Because a lot of his care could have been improved if we had caught him earlier, because time is long lost. The longer we wait to send them to be evaluated, the more lives I'm also losing. All right. So just to kind of highlight why I'm talking about this case, I do want to highlight this particular study that was done, I believe, in Denmark. In Denmark, they have different system. They have a system where all patients diagnosed with ILD have to be referred to the all patients diagnosed with IPF, idiopathic pulmonary fibrosis, have to be referred to one of the 3 ILD centers to be diagnosed with IPF and started on treatment. So they had a pretty decent cohort of 194 patients. And on average, that they found that the median diagnostic delay from the time patients had symptoms to the times they came to the ILD center was 2.1 years. Okay. And as you can see, the cause of patient delay is really multimodal. It's not one place that is causing primarily delays. You have patient delays from the time of onset to the time they see their primary care physician. The patient delays, oftentimes they attribute it to older age, just, being tired, doing less. So a lot of times ILD patients do come later than normal. You have GP delays where patients are not referred to the ILD centers or pulmonologists in a timely fashion, or they might attribute it to COPD, treat them for a longer time with inhalers, or inhalers might help some. So they might think of, just maintaining the current regimen. And then there are delays from the community hospitals where the pulmonologists are. And then there's delays after they have been seen in the ILD clinic, like in this patient, that there was some delays even after I saw him to getting him to where he needed to go. So majority of the delays actually happen at the level of the primary care physicians and the community hospitals, which is why we are focusing on this talk right now. Okay. And the risk factors associated for delays include male gender, age, use of inhaler therapy, like I had mentioned, and misdiagnosis of respiratory symptoms. Because the respiratory symptoms are very non-specific, it's often easy to kind of attribute it to something else, asthma, COPD, without actually realizing that that could be something more. And on average, sadly, they had found a diagnostic delay of 0.9 years to 5 years. 5 years is a lot of time for somebody who has ILD. In that time, you wonder how many people died before they even reached you. All right. So this is a study that was done in Columbia Transplant Center. They had studied patients who met ATS criteria for IPF, and they studied their time from onset of dyspnea to the date of evaluation at a tertiary center, like Columbia for transplant. This is irregardless whether they got a transplant or not, but basically just to illustrate that the longer it takes from the onset of dyspnea to the time they're seen at a tertiary center or an ILD center or transplant center, your mortality is incredibly high, as you can see. If you have a year, you still have a pretty decent mortality drop within a year. 1 to 2 years, greater drop, and more than 4 years, within the 4-year period, you have 20-30% of the people still alive. That's crazy. In that time, a lot of these patients might have been admitted for different causes, died from respiratory illnesses, and it wouldn't have changed the trajectory if they were not seen in a center that could help them differently. All right. All right. So why am I targeting this talk this morning? Right. So ILD in particular, it's a rare disease. It's supposed to be a rare disease, or they say so. National prevalence is only 70 per 100,000, but West Virginia's prevalence is 2,200 per 100,000. The causes for high prevalence include excessive smoking rates. We have coal mining. We have pretty severe obesity. And we have a very, very rural landscape in majority of West Virginia. So actually a pretty interesting study, even for me. This was across the Veterans Affairs database. So they studied patients from all across the country from 2010 to 2019 to see where the highest prevalence of IPF was. To our surprise, West Virginia is only second to Montana for the highest prevalence of IPF. IPF in itself is supposed to be a rare disease. If you think about it, it's ILD and IPF is supposed to be a rare disease, but it's not rare for us. Considering we have such a high prevalence, it is not rare for us at all. Okay. So what are the symptoms of ILD that we should think about? The whole purpose of this talk is to highlight how that we should think about ILD if we have a patient who comes into you with shortness of breath because of our prevalence being so high, and what can we do to kind of tease out that details. So symptoms are very non-specific. Most of our respiratory patients come in with subacute chronic symptoms, progressive trouble breathing, exertional dyspnea, chronic dry cough, very non-specific. Okay, so that's not going to help you distinguish if somebody has ILD or not. So on examination, there are a couple of things that might make you wonder if they could have ILD. Oxygen desaturation with ambulation. Oftentimes, this is the earliest thing we identify before we identify that they have ILD. Okay. Typically, COPD can cause hypoxemia with ambulation, but that's usually more progressive. This oftentimes is the first presentation I see. Hypoxemia at rest, inspiratory Velcro-like crackles, which I'm going to play that in a moment, and digital clubbing. Let me see if I can play this. Can you guys hear it okay? Okay. So just to highlight your physical exam finding, so the Velcro crackles are, it's like a Velcro being opened, all right? It's very different from the wet heart failure crackles that just sound, they just sound more congested, more wet as compared to this, which is a very dry sound, okay? So risk factors for ILD, smoking history, occupational exposures, which include coal, asbestos, silica dust, connective tissue diseases, vasculitis, sarcoid, exposure to birds, certain drugs such as amiodarone, methotrexate, and recently with the invent of more chemotherapies, we're getting a lot of chemotherapy-related ILD as well, and obesity. So on CAT scan, majority of the times the ILDs are diagnosed on CAT scan. What are some words that might pop up on your read or when you look at the images? The words are interstitial markings, reticular markings. All of this talks about some level of fibrosis. Okay, traction bronchiectasis, which basically means distortion of the architectural part of the lung because of the fibrosis. You have honeycombing, which is what you see right here, where it's layers of cyst. You have a different gradient, and in some patients, it's more ground glass first, where it's kind of hazy as compared to having overt fibrosis. So the thing with PFTs, a lot of times the PFTs are in the beginning, they're not going to help you diagnose ILD, especially a spirometry. If you have a look out here, the typical ones that we look at with the basic spirometry is your FEV1 to FVC ratio more than 70. This is normal. So oftentimes, if we just order a spirometry, the spirometry is going to not help us identify that there is something abnormal. So the earliest ones that would tell you that there might be some ILD would actually be total lung capacity, which might show some restriction, and your DLCO, which might show severe impairment. Okay, so spirometry on its own will not likely help you to diagnose ILD or suspect ILD. I would recommend doing a more complete PFTs if you suspect some patient has ILDs. Okay. So there are a couple talks that I want, a couple things in particular. ILD is very broad. I'm not able to cover all of it right now, but a couple that I wanted to highlight on, and these are the 5. All right, so IPF, as we all know, IPF is a very high mortality, about 3 to 5 years after diagnosis. Okay, this is a disease that's irreversible, and there are only 2 treatment options, which is pirfenidone and nintedanib. And unfortunately, these diseases do not reverse the trajectory of this disease, okay? They do not reverse all the scarring. They don't reverse the quality of life of the patients. All they do is slow the progression of future decline and reduce the risk of IPF exacerbations. So really not great options, but at least we have something. And if you have a look at IPF on a mortality basis, 5-year survival, it is worse than most cancers. Most common cancers, skin, prostate, breast cancer, it's actually much worse in a 5-year survival than majority of our common cancers. Hypersensitivity pneumonitis is a different kind of disease that is a genetic predisposition to certain organic material. So even among interstitial lung diseases, there are fibrotic and non-fibrotic. In the natural trajectory that when something has already become fibrotic, obviously the mortality and the prognosis is worse. But in a patient who has non-fibrotic, that means they haven't scarred, those patients are more reversible. We can even completely reverse their disease if we catch them early and treat them appropriately, okay? But oftentimes if we can limit the exposure to the inciting agent, which could be mold, which could be birds, they have a more favorable prognosis. And for patients who have fibrotics, even for patients who have fibrotic ILDs, how they look on the CAT scan and also determines how their disease progresses. And I'll come to that in a moment, okay? So treatment options for hypersensitivity pneumonitis includes removal of inciting agents, steroids, immunomodulators such as CellSAP, Amirah, and possibly antifibrotics for progressive pulmonary fibrosis. This is one that I want to spend a little bit more time talking because oftentimes we do have a lot of these patients, okay? Co-workers pneumoconiosis in West Virginia and this region is not uncommon. You can have silicosis adjunct with that and asbestosis. So there is a difference between simple and complicated co-workers pneumoconiosis. Simple, it means less than 1 centimeter, the nodules. Complicated is more than 1 centimeter, the nodules, okay? Like you can see out here, this is more complicated. So the complicated pneumoconiosis is also called progressive massive fibrosis because in definition by its name, it's a progressive disease that will continue to scar the lungs. So progressive massive fibrosis, I'm going to touch a bit on this because we have tons of patients of this that we don't recognize the severity of this disease. So PMF is an advanced, debilitating, lethal form of co-workers pneumoconiosis with almost no treatment. Okay, and back in so NIOSH and a couple of other places work closely to monitor our PMF rates across the country. And back in 1995 to 2000, they were actually, PMF was almost eradicated. It was almost eradicated. So among patients who are active underground coal miners who had worked at least 25 years, the rate was 0.33%, which is wonderful. However, since then, the uptake has been so remarkable that back in 2012, the rates were 3.23. We went from a disease that was almost eradicated to now a disease that is so prevalent that we have every 100 coal miners, 3 or 4 of them might have PMF, a lethal disease. That is a very, very high statistic, okay? I'm going to move gears to connective tissue disease-related ILD. So it is most common in certain groups of patients, such as patients who have rheumatoid arthritis, scleroderma, Sjogren, and myositis or dermatomyositis. Typically, the age group with connective tissue disease is younger, more women. And again, that can be fibrotic, it can be non-fibrotic, and patients with a UIP pattern. So UIP pattern basically is similar to the pattern that IPF has, okay? Which is why they associate it with a worse prognosis. And treatment options are limited, include steroid, immunomodulator, antifibrotics. And if you have a look at this, this image, so you would think that somebody who has rheumatoid arthritis-related ILD cannot be as bad as IPF, right? IPF is bad, but that's really not true. So even among that category, patients who have RAUIP, that means a pattern similar to IPF, the prognosis is pretty similar to IPF. Or patients who have RAUIP have a better prognosis. So yes, even among these groups, even though we think of IPF as a bad thing, even among these other groups, you do have bad disease too, based on how their radiological presentation is. And if you have a look at this, if you have a patient with undifferentiated ILD, and unfortunately, because of the lag time for them to have symptoms, be evaluated, and come to me, by the time they come to me, oftentimes it's tough to diagnose them. And sometimes the pictures don't fit typical characteristic IPF, HP. So some of them are undifferentiated ILDs, and oftentimes these are the ones you see in the hospital with recurrent admissions. Okay, their mortality is 1 to 2 years. That is a very, very high statistic. Just think about how many of these patients would have died before they even get evaluated, right? And if you have a look at IPF, it's still pretty bad, 3 to 5 years, but the others are on a spectrum depending on what kind of radiological symptoms they have. Okay. So the whole purpose of this talk is to collaborate with the primary care physicians, with the community pulmonologists, so that we can improve the care of these patients. So CHEST with this grant has a host of information for primary care physicians and pulmonologists to refer to if they suspect they might have patients with ILD. And this page should be accessible to everybody to have a look. And we are happy to send it through Kelly if anyone's wanting to look through it as well. And on this page, they do have a poster. And if any of you guys would like for us to send the poster out to you, please let us know. Jordan can help us coordinate this. And we have tons of resources for this, okay? So if the first step in suspecting somebody has ILD is if you have those symptoms I spoke about, if you have hypoxemia with exertion or at rest, and that typical Velcro-like crackles, okay? If you have ILD specific symptoms, ILD specific risk factors such as coal mining, such as being in Vietnam War where you're exposed to Agent Orange, which is also associated with IPF. Please also think about that. Okay. Recognize other potential symptoms. Because our symptoms are non-specific, please also think about cardiac, think about asthma, COPD, so we don't miss something like a severe angina. And then the next step to confirming ILD would be to order appropriate imaging. And the imaging of choice for patients you suspect with ILD is a HRCT, a high resolution CT scan that is non-contrast. Okay, I want to highlight this. A lot of times we get sent to us, patients who have a CTPE, but the ground glass from the CTPE can make it look like that is abnormal, where it might not actually be abnormal. Okay. And if you've ordered a CAT scan for whatever reason, and the comments mention interstitial changes, reticular changes, traction bronchiectasis, honeycombing, please consider follow-up PFDs, full PFDs. Please consider sending them to an ILD specialist to get evaluated. All right. So at a primary care level, consider smoking cessation, age-appropriate screenings, preventative vaccinations. I do want to highlight majority of the times the reason I've seen my patients pass away and have increased mortality is due to illnesses, acute illnesses. Okay. And they take a longer time to recover than we do. And if you are a pulmonologist, consider referral to a lung transplant center at an earlier stage. Provide ILD education, provide them with expectations on the progression of the disease. Make sure you give them oxygen if they need to. Let them talk to them about the supportive groups that are available, goals of care, for a pretty extensive discussion depending on where they are on that spectrum. All right. So we are also happy to send this out. This is a bridging specialties timely diagnosis for ILD questionnaire. So instead of having to ask your patient every single question, we are happy to provide this. It's also a Google search away that you can print and let them fill out if you suspect they have ILD. Okay. This is just a couple more of the questions. So CHESS in itself also has a self-paced early detection for ILD module that you can walk through to see, to kind of have a feel for what are the different kinds of ILD, how would you go about diagnosing them. And they have a decision-making tool with 3 different patients to kind of highlight, how each of them could be different, just to have a feel for what could be different for each patient. When do you need to have the suspicion for some certain kinds of ILD? And all of this are available. Please use it if you feel that would be if you commonly see these patients. So this is where we want to be part of this process. We want to be able to prevent these patients from getting worse and being evaluated in a timely fashion. Just like Charles, by the time he had seen me, unfortunately, it's too late. There's not much I can do for this gentleman, except for getting him evaluated for transplant. We don't want to catch our patients right when they're trying to, be really sick that they could die in the next couple of months. We want to catch them early so that we can monitor their progress and have these difficult conversations with them. So part of our initiative, we have one ILD center in Morgantown, and we have 1,253 primary care clinics in our state, which is a lot for having only one ILD center. Our goals is to improve the number of referrals to our ILD centers and our care providers by 25% by December 2024. And we are getting there slowly, right? And our focus is multifaceted. Getting patient delays, with relation to patient delays, we don't directly see these patients out in the field. So we have collaborated with NIOSH to target patients who are high risk, and among patients who are exposed to crystalline silica and fabrication workers or coal miners, we have reached out to see what is it that we can collaborate with them, even if it is providing the coal miners with education about what are the disease, what are the symptoms, when you should seek help. We are reaching out to primary care physicians, family medicine physicians, residents. The ECHO project is one of these. We are also planning to send out iPads to clinics with this information, with the surveys pre-filled. So if you guys have a clinic that you believe that will be helpful, please let us know, reach out to us. We have plenty of posters that can be sent out so that the ILD diagnostic evaluation can be put up at a place that might be commonly frequented, okay? To pulmonologists and rheumatologists, we're talking about the referral process. And in our ILD clinic, we're trying to expand our services via telemedicine. We're still working on that aspect. We're getting a clinic navigator, and we're trying to simplify the entire referral process so it's easier for people to send to us. And I want to highlight this. It's not necessary to be sent to a pulmonologist and then to be sent to us, okay? Because that also adds to time. If you feel that this patient has ILD, please feel free to send them directly to us from a primary care office, as long as the patient is willing to be evaluated. So we have access, like I was mentioning, we have access to the ILD toolkit on the iPads, and we are planning to disseminate this to multiple places. So if you're interested, please let us know. We have tons of primary care clinics in our region, and our target is to get as many as we can. All right, and this is our order set. If you do need to get a hold of us, just remember my name or call our pulmonary office and they will let you know. I'm one of the few that do pulmonary ILD in our office. And there is already an order set, an order to ILD clinic in POC, which is in Morgantown. Okay, so you don't have to send to somebody else before you send to us. And these are our team members at this point in time. We have a couple new folks who are joining, but unfortunately they haven't started yet, and I'll incorporate them once they do. Dr. Sangani was the ILD clinic director. He has left as of July 1st, so very recent. But please feel free to reach out to me and Dr. Ahmad if you guys have any questions on this matter. And this is a collaborative effort with, Dr. Ahmad, Dr. John Lee, and Dr. Farah Anwar, both of them who are fellows. Okay. I'm going to stop here. I think I'm done. I just want to see if there's any questions, any comments. I went over by a couple of minutes. I do apologize.
Okay. Does anybody have any questions?
Any comments? Do you guys see these patients? Do you guys see a decent amount of ILDs in your line of work?
Tara said that they see them in pulmonary rehab.
Yeah, we commonly send them for pulmonary rehab. If to be honest, in my opinion, the only thing that I have seen really help the patients in real time, not in a future aspect, is actually pulmonary rehab. So I definitely appreciate, Tara and the team for doing that, because that is the one thing that they always tell me helps them the most.
Would anybody else like to give some feedback? Does anybody see this in your clinic setting or in a hospital if you work in a hospital? All right, well,
Well, if you guys have any, hi, Dr. Weissman. If you guys have any, if you guys want to get some of the posters, the patient questionnaire, please reach out to us. We are happy to send it to wherever you need it to be sent to. We have tons of resources for that aspect. And Jordan Holloway would be our contact person, okay? Dr. Weissman, hello.
Hello. So I had a question for you, kind of a healthcare delivery question. I know WVU has the mobile unit that they send to do lung cancer screening. Is it possible to order non-contrasted CT scans for ILD patients through that mobile unit so patients don't have to travel?
I don't know yet. I am happy to ask Dr. Chapman who runs that, but I don't know if that's available just yet through there. But that's a great thought.
all right, Amirah. So Grace had asked, is there only one center in West Virginia for evaluation for ILD?
So we have one ILD center in Morgantown that I know of. Some of the pulmonologists in the neighboring areas, even within WVU, do manage these patients on their own, and that's okay. What we want to do is, if there is patients that might need a additional look on what else can be done, we want to be helpful. We don't want to capture all the ILD patients because it's not possible for us to see all the ILD patients. But if somebody is not following the trajectory that you expect them, or they continue to decline, or if you've started them on treatment and it's not working, we would rather see them. That's what I'm trying to collaborate on, because it's not possible for us to see with how much ILD there is here. It's not possible for us to see all of them.
All right.
Okay.
Well, thank you, Dr. Amirah. So everyone, we are going to have our next session. It's going to be at noon. So everyone, please take note and remember our sessions are moving to noon on Mondays. That will take place on August 19th. And we're going to have Dr. Weissman talking about silicosis. So once again, thank you. I'm going to send around an email from Dr. Abdullah that's going to ask for you guys to scan and do a survey, and then I'll do the follow-up email and everything. So thank you guys.
Thank you very much, Kelly. Appreciate it. You guys have a great day.
Thank you,
You too.
you as well.
Take care.
Bye.
Bye.